one could really outline the bronchial epithelial cells very readily and tell that there were neuroendocrine cells. We took this to another level, performed ultrastructural immunohistochemistry using colloidal gold particles, and we were able to show that with these small black particles here, that this target was actually within secretory granules, as is shown in a pheochromocytoma here. And if you look at other neuroendocrine tissues and using gold particles of different sizes, one can see that in the pituitary tumors, with the small and large gold particles, that these were localized with hormones as such in secretory granules. So we have characterized this by staining many, many markers and published our findings and subsequent findings. Today, we know that the really most helpful markers for neuroendocrine tumors include chromogranin and synaptophysin. There are other markers that are used, such as NSC neuron-specific enolase, CD56, but in my opinion, if one has positivity with those only and not chromogranin or synaptophysin, one can't be sure that you're really dealing with a neuroendocrine tumor. Here's chromogranin. It's not only chromogranin A that we've characterized, but many other members of the family that are localized in secretory granules within the cell in the schematic. And synaptophysin and the family of these synaptic vesicle-associated proteins are present within many of these cells. So we were able to come up with a really good definition of neuroendocrine cells and tumors derived from these, as can be seen here. But the essence of this was that one had these cells and tumors derived from these with secretory granules. They had chromogranin and synaptophysin as some of the markers in neuroendocrine cells. There are other markers that one can use in addition to these two, and NSC and CD56, but are not used very widely in our diagnostic surgical pathology world. Two of these are the proconvertases, and we showed many years ago that if one had these enzymes which are processing hormones from a prohormone to a hormone level, are processing the hormone further, such as pro-opiomelanocortin, one can detect these relatively easily with specific antibodies in neuroendocrine cells. Not in non-endocrine cells, except for a small percentage, are endocrine tissues such as follicular cells of the thyroid. So this would be another marker that would be useful. There are others that have been generated on a regular basis. One of our residents at the University of Wisconsin in Madison, Dr. Jason Resimont, has characterized at these meetings and has several posters presented, and will present another one tomorrow, showing that a marker called INSM1, which is a transcription factor, is really a very nice, very powerful marker for characterizing neuroendocrine cells as well. So the discovery of these markers continue even today. In terms of things that have gone on in recent years in the development of chromogranin A nice review published a few years ago has shown that chromogranin and secretogranins can function as regulators of cardiac homeostasis and of hypertension. And that plasma chromogranin A can be used as a cardiac marker for myocardial infarction, which certainly isn't needed with all the markers we have, but also for heart failure. And I'm sure Dr. Maude Abbott would be very interested, if you were around today, to really know that these are being investigated. Preliminary studies have also shown that decreased chromogranin A in the CSF can be associated with early onset Alzheimer's disease. Long ago, this isn't a recent development, this first bullet, but we had shown that chromogranin A is present in many endocrine cells and tumors, but not in all. For example, if you have prolactinomas in the pituitary, or if you have hindgut neuroendocrine tumors, many of these, about a third or so, may be negative for chromogranin A. So combining an antibody to chromogranin A and chromogranin B is a powerful way of increasing the sensitivity of these markers, but the commercial outfits have not taken advantage of these to market these together, as far as I know. Another recent, and certainly for the past few years, which is used by the oncologist, is that serum chromogranin A can be used to monitor recurrence as well as persistent of neuroendocrine tumors. So just drawing blood, measuring it, can really be helpful in following patients. And an area of really very active research in the biology of chromogranins is that the proteolytic products such as pancreastatin and catastatin have really specific biological functions, and these are being investigated by many individuals today around the world. The second case is that of an 86-year-old woman who had a right thyroid mass which was present for at least 3 years. The resected tumor measured 2.5 centimeters, so it's a relatively small tumor, but there was extrathyroidal extension with involvement of the tracheal ring and larynx. So it was a very aggressive tumor, as one can see from the history. She had developed local recurrence and lung metastases 2 years after surgical resection of the lesion. This is the histology of the resected surgical mass. You can see that it's composed of elongated follicles, and if you're up close, you can probably recognize the enlarged cells within the tumor, which in higher power shows histologic and cytologic features of papillary thyroid carcinoma. So one has cells that are with overlapping nuclei, some nuclear clearing in some areas, and features that one associates with papillary thyroid carcinoma. The tumor also looks very aggressive histologically in that one has, at the periphery of the thyroid, one has invasion of a blood vessel by the tumor cells. And then the final high power view showing the orphan Annie-type nuclei that one can see in these papillary thyroid carcinoma. Notice that the cells are rather tall, and so this would be designated as a tall cell variant of papillary thyroid carcinoma. This variant was described by Dr. Hazard at the Cleveland Clinic, and in a report that he published in the Cleveland Clinic Quarterly in 1975. And this was sort of a summary of all his impressions and all the extensive work that he had done over the years and having observed this. So when I was at Michigan in my early years there, we decided to investigate with a case control study to see if the tall cell was really fairly more aggressive variant of thyroid tumor. Dr. Hazard had mentioned that these were commonly seen in his experience in older patients, males, who presented often with bulky disease. So we worked at this, and the resident, Dr. Terry Johnson, was very helpful in pulling a lot of the data together and was the first author of the paper that was published in the American Journal of Surgical Pathology about the prognostic implications of tall cell and papillary carcinoma. Terry was a very talented pathologist, and I should say that she passed away about 10 years or so ago, and her passing, of course, was really a great loss to diagnostic pathology. But she got the follow-up history of the patients, and we compared a control group of usual or conventional papillary thyroid carcinoma with this group of 12 patients that we had. They were matched by age as well as sex. Tumors were slightly different in size and with the follow-up period. But as you can see very dramatically, even without statistical analysis, that these tall cell variant was certainly a very aggressive tumor in which patients had distant metastases, and some patients died of their disease in this group compared to the control group. This paper, I was proud to say in retrospect, was accepted when we submitted it to the American Journal of Surgical Pathology without revision, because over the years we've rarely, if ever, had a paper that was accepted right out without revision, as probably is the experience of many individuals in the audience as well. And this entity is so well known with all of the publications that when we go to our endocrine tumor board, the endocrinologists who are not that familiar with morphology are always asking when we present a very aggressive tumor, is this a tall cell variant? Very knowledgeable, at least about the behavior of the tumor. Here's another example of tall cell. Some individuals say that these are often difficult to recognize or diagnose, but it's really simple in terms of the elegance of seeing the really tall cells, 2 to 3 times as tall as they're wide, and one can predict from this morphology that these are going to be more aggressive. We know that they usually have a higher rate of mutation of BRAF V600E, which is oftentimes a marker of more aggressive thyroid papillary cancer. And at closer view, cytologic features such as the nuclear holes, the pink holes, and other features of papillary thyroid carcinoma. After we had published the original paper, we did further studies with this. This is Dr. Andrew Flynn. Andy and I started at University of Michigan, actually on the same day, and we even shared the same office because the new hospital was under construction at the time. And then when the hospital was finished, we moved, but our offices are right next door to each other, so we continued to talk about current problems and doing collaborations. Andy was very good in morphometric analysis and DNA, ploidy and other analyses. So we examined a series of cells and found that there were subtle differences, but no major differences at that level between the tall cell variant and the usual papillary thyroid carcinoma. But there have been some major observations in the last few years about new developments with tall cell. For example, in the original paper with Terry Johnson, we indicated we used 30% as a cutoff between what we considered as tall cell variant in predicting the aggressive behavior. But recent studies, one with an abstract presented at the USCAP meeting in 2012 from Europe, as well as a recent full-length paper, has shown that even if you have 10% tall cell features or areas within the tumor, these are going to be fairly aggressive tumor, even with that small percentage. And that's certainly very good and very useful to know and to convey to our clinical colleagues. Another major advance is work done by Tom Giordano at the University of Michigan and Dr. Getz, and working with a large group of individuals, endocrinologists, many pathologists, have shown very elegantly in this publication in Cell a few months ago that the entire major genetic findings of tall cells have been elucidated, and so one can use this knowledge to really probe the molecular genetics and possible coming up with other treatment for more aggressive variants of this papillary thyroid carcinoma. The final case is that of a 63-year-old woman who presented with a 3-centimeter right thyroid mass. She had, at the time of workup, this was done at the Mayo Clinic, there was a 1 centimeter long nodule that was present during this workup. She had a total thyroidectomy and selective right cervical lymph node resection. The tumor was positive for TTF1, P53, which were some of the markers we did later on in working up this series of cases, as well as thyroglobulin. And then we also, in the recent workup, found a BRAF V600E mutation in the lesion. Here is the histologic appearance of this, in which one has cells that are follicular variant of papillary thyroid carcinoma on this side, and then these are other cells in which one has cells that are obviously have larger nuclei, as you'll see later on, other features that suggest that they may be more aggressive, but suggestions here of the hobnail pattern to some of the tumor cells. A higher view showing the hobnail pattern, accentuating this within the tumor cells. Another higher view showing that the cells have large nuclei, prominent nucleoli, and even mitotic activity. As many of you know, it's rather uncommon to see very many mitotic figures in usual papillary thyroid carcinoma. And another view accentuating the hobnail pattern, reminiscent of tumors that one sees in ovarian clear cell carcinomas and a few others with these hobnail features. The tumor had metastasized in the lung, and here it was in the bronchial wall, in the case showing nests of tumor cells, very unusual for the typical or usual papillary thyroid carcinoma. And within the lymph node, one sees again the hobnail pattern, but also a micropapular pattern.